So we're on. Welcome to Doc Talk Live.
Awesome. Yeah.
I appreciate the technical difficulties, but I am a physician, not a computer expert. And I'm also not a millennial, so social media is still a challenge for me. I'm in my office in Birmingham, Alabama. I appreciate you. You know, it looks like you just got out of the operating room. You still have your lead on, Ankur.
I literally just scrubbed out and came straight to the computer. I was trying to make that 4:45 clock, and I don't think I've ever closed that fast in my life.
Awesome. Well, I'm glad I put the pedal to the metal for you. So you're outside of Houston, is that right?
Yeah, so just about an hour north of Houston, a little suburb called the Woodlands.
And you do, is it interventional pain? Is that
Yeah,
accurate?
so that's right. So anesthesiology-based interventional pain guy.
So, okay, so I'm PM&R based, you're anesthesiology based. Interesting. So that's, and how long have you been practicing in private practice?
Yep. So I hung a shingle straight out of fellowship, and that was 14.
Where did you do your fellowship?
Down in UTMB Galveston.
Galveston. Okay. That's not where Rax is from, is it?
No, Rax was up in Lubbock.
Lubbock. Okay.
Texas Tech. Yeah.
So we were going to talk a little bit about, I'm going to call it a new procedure. I've only done a couple of them, a handful of them. We're going to talk a little bit about the Minuteman device, which is an intervention, a minimally invasive intervention for patients with back problems. And I think of it for folks with spinal stenosis, although I am sure this device could be used for many different types of spine-related problems. But maybe we should just stick to spinal stenosis. Is that your experience with Minutemen?
Yeah, I mean, I think I've seen some tremendous successes when we're looking at those patients with degenerative disc disease. And so you're right, right? You and I both know that when we put any narrowing of that column, which is the spine equaling spinal stenosis, our patients are going to end up with that chronic back pain, leg pain. But I think we can also look at patients that spondylolisthesis, grade 1, grade 2, because this is a more secure option for a minimally invasive approach to that condition.
So let's let, because this is really geared toward the lay people. Let's define some terms. First of all, what are the symptoms that patients generally have? What's the age group, and what is spondylosis and spondylolisthesis? So let's really sort of simplify it a little bit for our viewers.
So I think the easiest kind of, if we were to use the broad category for who this would apply to, it's your 55 and up. That's when the spine is really starting to. I like to call the little vertebral bodies or the bones that make up the spine, I call them the little Jenga blocks, which make up the full tower. That tower is held together with a bunch of ligaments and cross structures.
Let me just get you to speak up a little bit, Ankur. I'm sorry.
Yeah. How about now? Is that a little better?
I think that's better. Yeah.
Great. Yeah. So it's that leaning tower of Pisa when all those Jenga blocks, which make up the spine, start to tilt, and the disc doesn't have as much shock absorbing potential as it did in its native state. And so we see that there's different parts to the spine that pick up weight as we age and as it deteriorates. Symptoms might be sciatica, right? Where you've got that numbness tingling in your back, going down your leg. Some people just have chronic back pain. When we're talking about spinal stenosis, I look at that, I'm sure, Brad, you see it the same way, as that shopping cart sign, right? When you see our patients, they're at Walmart or the grocery store, and they're leaning forward. What they're trying to do is take pressure off those little neural elements or those nerve fibers in the spine And so the Minuteman is a great tool to be able to support the spine in that forward position, but allowing the patient to stand upright and not have to endure those symptoms.
I'm glad you brought up the shopping cart sign, because basically what patients are trying to do is they are trying to naturally decompress the nerves in their back. They're trying to decompress the spine. And so when they forward flex, it opens up the spinal canal and takes some of the pressure off the nerves. It makes more room for the nerves. And what's interesting is sometimes, they come in with their significant other, and the significant other would say, his posture is so bad. He's always bending over to walk. We've got to correct that. And I'm like, he's doing that for a reason, and that may or may not be correctable, because you're going to make him feel a lot worse by standing straight up. So it's that standing straight up. But so the Minuteman device is a spacer that you place between the vertebrae in a minimally invasive fashion that indirectly decompresses the spine. Am I saying that right?
Yeah, I mean, I think one way to look at it is like a spacer, but maybe zooming out a little bit further, it's a way to support the spine, because the way that we deliver it and secure the device, as you've seen, it tends to lend a little bit more structural integrity than a traditional spacer might.
Yeah, a traditional spacer, I guess, in a minimally invasive fashion, really only would block extension at that segment. Definitely. Whereas this would, like you said, actually create integrity. So anytime you've got what I call a sloppy spine, where that segment is unstable, it would stabilize it.
That's absolutely right.
Absolutely. That brings up another question I have in my mind, because, I've been out for 20 years, you've been out for 5 years or 6 years, but these minimally invasive devices have only been around for a couple years. And so that's where the surgeons, I think, have a leg up, is that they are used to seeing these sloppy spines and intervening, whereas we were just doing blocks and, let's say, spinal cord stimulators.
Yep.
Now we have a way of addressing the instability. Sometimes I struggle with, how do we know that the instability is in the posterior or the back elements of the spine, as opposed to, let's say, in the middle column or in the pars. So if you address the back of the spine, you may not be doing anything if all the motion is in front of that. Do you see what I'm saying?
Yeah, so, and I think that also comes down to all the cross structures that we have, right? Anterior longitudinal ligament, posterior longitudinal ligament. So yeah, if there is motion on the front part of the spine, even though the disc is degenerating in the back, because of that unique bone, so we put that little bone plug in the middle of the device.
Right, but if you put, let's say, a pedicle screw in, the screw is going through the pedicle / facet into the vertebral body, and it's basically going through all 3 columns of the spine.
Sure.
Whereas with this device, you're only stabilizing the back. And if that's where all the motion is, then that's all you need. Right? It's how do you determine, where that instability is? That's something that I stay up at night thinking about.
Got you. I mean, I think that then comes down to, good imaging, good pre-op imaging, getting FlexX x-rays, having those discussions. And, that's what I'm doing now, is having those discussions with my spine surgeon, because it's not the same conversation that we used to have before, which was, all right, epidural steroid injection, move on. Right now, the conversation is actually elevating to another level where we do have to take those things into consideration. And, how do we team up with our colleagues to allow them to have more time to do those that are anteriorly unstable versus these procedures where we can help intervene.
I would like to just try to point out to the viewers that these devices are generally placed between these two bones, the spinous processes. And with the Minuteman, one comes in from the side and it's percutaneous. So it's not an open procedure. It's done with, well, you're the anesthesiologist. We don't put tubes in. We just give them a little Valium, a little Diprovan, and the nurse anesthetist and anesthesiologist does it. But it's not under general anesthesia. Do you do these under general or local?
Yeah, I mean, I think it's really patient specific, right? We've heard the stories of people doing it completely under local. In general, yeah, just a little propofol, a little Diprovan, and people are good. The case that I just did, the guy woke up saying he didn't even know he didn't even feel like he had a procedure. He was in no pain. So it really can be done with a minimal anesthetic.
So these folks go home the same day. They wake up pretty quickly. They get back to their usual activities. And I say that with a grain of salt because I tend to restrict them for several weeks. But they're basically driving and doing basic activities the next day. Whereas with a big back operation, that could be weeks before you can allow them to do things. So anyway, that's where the Minuteman device, it's put in between the bones. What are your thoughts on the decompression aspect of it?
So I think it's focusing on, that indirect component, where, and maybe if you can show our viewers that when we turn the spine to the side and you kind of lean forward, you're taking pressure off. See right there, that nerve that Brad just opened up, that's kind of what patients are doing on their own. So we just get an opportunity to support what they're already doing. And, it gives them the opportunity to at least try a procedure that's not going to be, very invasive with a major incision. I mean, you said weeks, it may even be months of recovery.
Certainly doesn't burn any bridges. That's the nice thing.
Yeah, and if something really needs to be done, it still can be. And
but I guess for me, and I am a believer in these indirect decompression devices, but to me the proof's in the pudding, and I want to see, and I don't have the experience yet because they haven't been on the market long enough, but I want to see post-procedure imaging a year later, 2 years later, that shows a change at that segment in terms of, by lifting up that segment, by doing that, you have decompressed the area. Do you know what I'm saying?
Yeah, and I think you're right. It'll be interesting to see how that data unfolds, especially with now that we're allowing more blood flow to the area. Even though the disc may be pretty avascular, those neural elements getting a chance to get more oxygen, get more nutrients, allowing somebody to build more muscle tone. It's going to be really interesting to see long-term studies on that. They have some studies that they've shown us where the bone actually fuses to the spinous processes. And then also, and I think my rep was telling me about the strength of this implant is as effective as 4 pedicle screws with the studies that they've recently done.
So on a personal note, where are you from?
So I was born in Toronto, And
Nice.
then I moved down to Dallas when I was 13.
So what led you from Toronto to Dallas?
My dad got a job transfer, so you kind of go with him.
But what did he do?
You remember this small company called Nortel Networks?
Yeah.
They made all those phones. That's what
Yeah.
he worked. He was an
Nice.
engineer for them.
Do you miss Toronto?
I do not miss the cold.
Did you play hockey?
Yeah, of course.
Do you
How
still
about yourself?
play? Do you still play?
No. Now my time is all spent in the OR.
All right. I grew up in Detroit, so I'm a Red Wing fan,
there
and
you
I
go.
still play. And the guy who runs our team is a big Maple Leaf fan, and
Wow.
yeah, big Toronto guy. So yeah, that's great. So you like it down in Texas?
Yeah, my years here outweigh my years up there. So I even wear boots pretty much all the time. I've assimilated.
Awesome. Well, it was great to talk to you. Do you have any other pearls you want to share with us about we should mention that these are older people in general that we're using these devices on. They're generally a Medicare population.
Yeah. What I say, other pearls on this is much like we try an epidural to get relief before jumping all the way to surgery. I think this is the next step before a big laminectomy infusion. I've been on some peer-to-peer calls where they say they have data to support that maybe this is the precursor to something like that, because you may save the patient from needing it at all.
Sure, absolutely. Well, keep up the good work. I've never been to Houston, so hopefully I'll get down there one day.
Hey,
You're
anytime,
outside Houston, right?
Yeah, outside of Houston. But anytime you're through, Mikasa Sukasa.
Okay. What's the name of your pain practice there?
University Pain Associates.
Okay. Awesome. Pleasure to meet you.
Likewise.
All right. Get back to work.
Will do. Thanks,
Thanks. Thanks, Ankur. Let me see how to stop this. Just a sec. Hold on. No, that's not it. We're still live. Let's see here. Stop live stream.